An airway fire is not a theoretical complication. It is a preventable catastrophe produced by the convergence of an oxidizer, an ignition source, and combustible material within the airway field. In clinical practice, the oxidizer is most often oxygen or nitrous oxide. The ignition source may be electrocautery or laser energy. The fuel may be an endotracheal tube, tape, or surgical sponges. The event begins silently, with a routine procedure that gradually acquires the three conditions of combustion. The smallest oversight, such as excessive oxygen concentration near an active heat source, can convert standard airway management into an emergent rescue scenario. When the fire is recognized, speed and coordination are essential. The first actions must occur simultaneously rather than in sequence, because delay permits deeper thermal injury and propagation into the tracheobronchial tree. The gas flow should be discontinued immediately to remove the oxidizer supply. At the same moment, the endotracheal tube should be disconnected to isolate the airway circuit. Concurrently, saline should be squirted into the operative field to extinguish active flames and cool injured tissue. In this crisis, no single maneuver is sufficient. The response depends upon simultaneous interruption of combustion, ventilation source, and airway exposure. After the flame is suppressed, the priority shifts from fire control to injury assessment. The tube, cuff, and airway mucosa must be examined for signs of charring, fragmentation, edema, and bleeding. A rigid bronchoscope should be used to inspect the airway carefully for residual debris, melted material, soot, or necrotic tissue. This step is crucial because concealed fragments may obstruct ventilation or continue to injure the lower airway if left in place. The bronchoscopic examination also helps define the extent of thermal damage and guides decisions regarding reintubation, ventilation strategy, and transfer to advanced care. Recovery of the patient requires disciplined physiologic support and close surveillance. Oxygenation should be reestablished with the lowest effective oxygen concentration, while airway edema, bronchospasm, and aspiration are anticipated rather than awaited. Analgesia, humidified gases, and repeated reassessment may be necessary. In more severe injuries, consultation with anesthesiology, otolaryngology, and critical care is warranted because airway compromise can evolve over hours. The apparent stabilization immediately after the event does not exclude delayed deterioration. A serious educational video on this topic should therefore emphasize not solely the mechanics of suppression, but also the logic of prevention and the discipline of post-event evaluation. The airway fire is a dramatic example of how a familiar clinical environment can become hazardous when combustible material, oxygen enrichment, and ignition are allowed to coexist. Effective management demands instantaneous teamwork, simultaneous termination of the oxidizing environment, saline extinction, immediate airway disconnection, rigid bronchoscopic inspection, and vigilant recovery planning. In medical education, the lesson is both practical and solemn. The safest rescue is the one that prevents the fire, but when prevention fails, coordinated action must be immediate, measured, and complete.